Hello, everyone, and welcome to Wheaties Virtual Spotlight, exploring the smart health insurance card. It's my pleasure to welcome Robert Tennant, Wheaties Vice President of Federal Affairs.
Thank you, Michael, and it's my pleasure to welcome all of you to today's Spotlight event, exploring the the smart health insurance card. So what we'll have today, if you go to the next slide, Michael, we'll walk through the agenda. I'll spend a few minutes talking about a little about who Wheatie is, for those that aren't familiar. We'll talk a little about the work that Wheatie did over the last few years. And then we'll turn it over to Ryan and JP to talk about the smart health card. They'll give a demo. We'll have a quick Q&A, and then we'll move into our expert round table to talk about the benefits and challenges. Next slide. So for those that aren't familiar with Wheatie, we were formed in 1991 by then Secretary of Health and Human Services, Dr. Lewis Sullivan. Two reports were developed by the original Working Group for Electronic Data Interchange that were then converted into legislative language that became HIPAA. And we were named in the law as an advisor to HHS, and we continue to have a very productive relationship with folks like the Centers for Medicare and Medicaid Services, the Office for Civil Rights, and the Office National Coordinator for Health Information Technology. We are a multi-stakeholder membership group representing all facets of the U.S. healthcare system. We operate through our 18 work groups and task groups, ranging from things like privacy and security to data exchange and all areas of the revenue cycle. We also have a new effort aimed at health equity. So if you're interested in getting involved in our work groups, please reach out. Overall, our roles are to convene, to collaborate, to educate, and to influence. And again, it's really our opportunity to bring experts together to talk about not just about the problems of healthcare, but actually how to solve them. Next slide. So I wanted just to give you a brief overview of some of the work that Wheatie's done. This is what you're going to learn about today with the smart card is very exciting, in particular for Wheatie, because we've been involved in this space for many years. We first identified really the opportunities around having a machine-readable health ID card back in the early 2000s. We formed a work group to see if we could develop an implementation guide, which we then released in 2005. We updated that in 2011, and I've included a link here to that IG. And you can see here the types of health identification cards with a barcode. We also had a mag stripe option as well for cards. And so we were very successful in developing that implementation guide. Next slide, please. But there was little industry adoption of the standard. And we revisited this ID card issue in our 2013 report, where, again, we called on the industry to develop actionable electronic approaches to sharing patient data using what we called smart technologies and applications. So again, looking ahead at opportunities to streamline this particular part of the revenue cycle. We also note that there's been an increased emphasis on patient-centered care, on the interoperability of health data and health security. We also recognize that many folks in the financial and the retail spaces have moved to smart cards, and an increasingly large number of health plans have moved to offering these virtual ID cards, again, to cut down on cost by having to send out these plastic cards. And in 2014, we convened the industry to see about standardizing not just the ID card, but we're also looking at standardizing the information that is traditionally captured on that clipboard that you sit there in the physician's office with a clipboard on your lap trying to remember what medications you're on and all the information they require. So we launched a virtual clipboard project in 2015. And if you go to the next slide, the idea was, again, you'll appreciate this when you hear what's coming a little bit later, but our idea was, can we use the technology that many folks have with their smartphones to move key demographic information, medical history, and insurance data over into the practice management system or electronic health record used by the provider, whether it's in the physician practice setting or the hospital. So again, the idea was, can we automate that movement of data? Next slide. So again, we didn't get the type of industry traction that we were hoping for. And so I've pulled out a few of the lessons learned over the years. And one is, of course, we all know the chicken and egg issue. Health plans are reluctant to deploy a technology unless providers can use it. Providers can't use the technology if their vendors don't support it. And the vendors won't support the technology unless the majority of payers adopt the technology. So everybody's waiting for somebody else to move forward. We also recognized very quickly that it's critical to engage with each key stakeholder group: patients, plans, providers, and vendors. And you'll note that we have all of these stakeholders represented on our call today. It's also critical to have consistent use of a standardized way of doing things, the standard and the format. It's important as well to establish tangible efficiencies for patients, payers, and providers. That's going to drive adoption. And then the question is, of course, how or should and how the government should they be involved in this type of activity? So, for example, could there be a standardized card for Medicare, Medicaid, Medicare Advantage, and TRICARE, all the health plans that the government oversees? And then, of course, we realize it's very important to start with an achievable use case. It's very easy to look at this technology and say, oh, look at the things that we'll be able to do. So we sometimes bite off a little bit more than we can chew. So start with an achievable use case and then move forward and expand into other areas. Next slide. So with that, and I will give you a quick anecdote. When WEDI did come out with our implementation guide for machine readable health ID cards, not many payers adopted it, but some did. And I happen to personally have United Healthcare as my carrier. And in the mail, I got my new plastic card that had a machine readable stripe on the back of the card. And so I was extremely excited since I was involved in the effort. And the next time I went to my physician's office, I ran in the door holding my card up with the mag stripe. And I said, look at my card. And they took it and they said, isn't that wonderful? And then they photocopied the card, of course. So we have a long way to go. But I think you'll be excited by the efforts that is going on today. This is an interactive event. You have the ability to ask questions, to raise issues. You can either do it through the chat, and you can, of course, use the chat feature here with Zoom. Or if you'd like to speak, please raise your hand and Michael will unmute you. As always with our WEDI spotlights, the slides and the recording will be made available to you after the event. So no need to ask for it. We'll be sending it to you via email. And with that, it is my pleasure to turn this over to Ryan and JP to talk about the Smart Health healthcare card and walk through the demo. Thanks so much.
Thank you. And so I'd like to kick this off by giving a little bit of introduction to the Smart Health Card technology, and then I'll turn it over to Ryan to talk about the work that's been done thus far to bring the digital insurance card attributes and work coming from the work that CARIN has done over the past several years into this, this technology, so that we have, sort of the unison of these two things, which represent the Smart Health Insurance Card. So hopefully with this intro, it will be clear what we're talking about as we dive into what I think should be a pretty interesting panel discussion. So again, we'll start with what is in fact a Smart Health Card. So those of you who downloaded and retrieved your digital vaccination records during COVID, you probably have a Smart Health Card either on your phone or printed out. Smart Health Card simply is a mechanism to download, share, present, convey reliable clinical information. So, one of the things that's been great about things like ONC's actions to get us all of our data via patient access is we can download records to our phone and we can share them as we like. But there's always been a little bit of a catch there, which is that those data are very difficult to verify once they leave the health system. And so the purpose of Smart Health Cards was, could we figure out how we could wrap up some of this clinical data in a particular kind of wrapper, such that when you share it, it doesn't matter how many times it's changed hands, whether it's on your mobile device or printed out on a piece of paper, it can be trusted when one receives it. Some of the important design goals and considerations for the Smart Health Card specification and technology was that it had to be an open standard, such that anyone could pick it up, use it, interrogate it, understand it, and include it in their technology stacks. It had to be accessible and equitable, meaning that it couldn't just be a mobile phone-based technology. It had to be something that could be printed out and carried by folks who didn't have access to such technologies. And then the usual stuff. We needed to follow the FHIR standard and specification for how data are conveyed. We needed it to be privacy preserving and secure. If we go to the next slide, please. So the brief technical overview, not going to go too deep into this, but want to just give just enough so that we make sure that we're all on the same page here as we move forward. So what is a Smart Health Card from a technical perspective? A FHIR bundle represents the clinical data payload. There are specific profiles that we've developed for certain profiles like immunization records and lab test results, but really any FHIR bundle will work. The W3C verifiable credential standard is used for signing, issuing, and presenting that FHIR bundle. So that's basically the secure wrapper that verifies the authenticity of the data inside. Smart Health Cards can be presented as a QR code that can be scanned by a specific reader. They can be shared as just a simple file. And there's also a specification for sharing Smart Health Cards via the existing FHIR APIs that many of us use. A trust framework then determines which of the folks who are providing Smart Health Cards are trusted. And there can be many trust frameworks for different use cases. An example of one is the VCI directory and Common Trust Network that was stood up during COVID for the immunization record Smart Health Cards. And last, there are plenty of free and open source tools that are available both to develop and issue Smart Health Cards, as well as to verify and extract the data. So no one is locked into any particular vendor or solution in order to use these. Next slide, please. Smart Health Cards were great for the particular use case during COVID of bundling a small number of immunization records into a sort of a concise package that could be shared completely via a QR code offline. But sometimes we want to share more data, or sometimes we want to share data sets that are dynamic. And this was the impetus behind the development of an extension of the Smart Health Cards work called Smart Health Links. So what Smart Health Links do is expand on that protocol so that users can share more kinds of data. This could be things that are too big. So maybe a complete immunization record that we couldn't possibly fit into one small QR code. It could be data that change over time or are generated in real time. So again, using the immunization example, my individual Smart Health Card proving my first dose of vaccine, that's going to be the set forever. But if I wanted one that changed over time and automatically added subsequent doses, then maybe a Smart Health Link could facilitate that. Smart Health Links can also include bundles of data, such as FHIR bundles, or they can combine multiple Smart Health Cards from multiple sources into one for easier sharing. And last, they can do other things like provision access to Smart on Fire APIs to simplify some of the different kinds of interactions that we regularly have throughout healthcare. Some of the use cases that are already underway. So I mentioned complete immunization records, and this fall we should see the first states and immunization registries beginning to issue smart health links for complete records. International patient summaries, this is a great use case for this, and likewise this fall you should see the first examples of this coming into production. Insurance card, obviously, as we're here to talk about today, and another couple of opportunities that have been discussed pretty regularly among public health departments is things like advanced directives as well as vital records. Next slide. So smart health links, again, an equally brief technical overview on this. So, much like smart health cards, a FHIR bundle defines the clinical data payload. And then you can take that FHIR bundle and simply place it and host it in the cloud at the end of the smart health link, or you can sign it as a smart health card if the authenticity of those data are required. The data are then encrypted. You can set them to expire. They can be protected by passcodes and several other measures that you can find in the specifications that help protect the privacy and security of individuals' data. The Smart Health link itself provides access to those artifacts, including the decryption key, so that when you receive the link or the QR code, you have all of the information needed to go fetch the records. Last, Smart Health links can be shared as a QR code or a URL. And likewise, the Smart Health link can include information about a web viewer so that people can even click on a Smart Health link and see the data without necessarily having to have specialized software to do so. And I'll also point out that the sort of default modes of sharing are via QR code or URL, consistent with our equitable access requirement. We have been working on various ways to transmit these using some of the later gadgetry and features of smartphones and digital wallets, such that we can have sort of more privacy preserving and secure methods of transmission, as well as better user experiences for those who do have smartphones. And like with smart health cards, there are plenty of free and open source tools available to verify, extract data, build your own smart health links and such. Next, my last slide, please. Just a quick note on the adoption of smart health cards to talk about what we're working with here. So, this is coming from the work in COVID, but I think it speaks to the fact that these technologies are relatively simple to implement. They're completely open, such that, again, you don't need to rely on any particular vendor to make this work. These are open source tools that should work irrespective of which particular parties you're working with. And these things have contributed to make it extremely easy to adopt smart health cards and for them to proliferate. So during COVID pandemic times, we saw availability of smart health cards for COVID immunizations reach over 500 million people worldwide. This was through efforts of federal governments, state governments in the US, the major pharmacies, health systems, insurance companies, and so on. And another major factor to the success of the standard has been support by the operating systems and digital wallets on both iOS and Android devices. Ryan?
Thanks, JP. Appreciate it. Next slide. I think folks are aware, but if you're not, we help also lead the CARIN Alliance, which is focused on getting consumers more digital access to their healthcare data, representative of about 80 different stakeholders that are involved in CARIN. But in addition to that, with the patient access API that's now live, had an opportunity to develop the CARIN IG for Blue Button, which allows for individuals to then be able to gain access to essentially all their explanation of benefit information. It's essentially the health plan payload. And as a result of that effort that's now been implemented in all the different CMS payers across the country, our payer community actually came to CARIN and said, we probably skipped a step in here, and we probably want to back up a step and figure out what we do with insurance cards. Because for us to get the payload for Blue Button, it makes a lot more sense for us to also then figure out a way to digitize the insurance card. We were careful not to call this an eligibility check. That's not what this is. This is essentially just a digitization of or an implementation guide related to the digital insurance card itself. So the physical card that's in your wallet what is this essentially the data model for how that should occur? And so a number of years ago, now we published the CARIN Digital Insurance Card Implementation Guide that's on the FHIR website. And as part of that, that is now we're working with folks like JP and Josh and others around how we actually take that payload and make that the core payload for providing that digital insurance card. So what you will see for those, especially in the FHIR community, is you're going to see a merger of these two standards. So smart health cards and what that actually looks like from a B2C perspective is going to be included as part of the digital insurance card implementation guide for FHIR. And we're going through the process right now of working with HL7 and the various work groups to ensure that happens. So really there's two different workflows here. There's a B2B workflow that actually when the payer knows the actual patient's provider that they've chosen. So during open enrollment, if you've selected your primary care provider, there's an opportunity for the payer to send that information directly to the provider's EHR system and allows for that to happen seamlessly behind the scenes. Everything is great. And so that you as an individual new member goes to your provider, you don't have to re-show your card. It will already have been sent by your payer to your provider. That's definitely a use case that is supportable by the implementation guide. The second use case, as JP mentioned, is the one we're talking about today, which is a situation where the payer doesn't know the provider that you've chosen. Whether you go to a specialty without a referral or you go to some other doctor for the first time, for example, a primary care physician, and the payer doesn't know who that doctor is, you're going to need to show that card and the other use cases that JP had mentioned. And so in that situation, you'll need a card that's associated with your wallet, which allows for you to then be able to show that digitally and do all the fun things that JP had mentioned. But I did want to mention that we do have that FHIR implementation guide and we're working together to bring these two standards into the same IG itself and go through the same process with an HL7 to make that happen. Next slide. So that is exactly what I was talking about. The payers are going to generate the actual FHIR bundle as defined by the CARIN IG, and they're going to generate that smart health link, as that signed copy of the insurance data itself, and provide it back to the member. Providers can then accept that, as we mentioned, either online or via check-in process. I know there are leading vendors like Epic and others who have a check-in kiosk, and so they have the hardware in place that they potentially could scan those cards. Moving forward, maybe not all EHRs have that technology, but the hope is that we can also work with the app and wallet makers to really understand ways that we can import these cards digitally. And that's really the breakthrough right now. We have really good relationships with the different wallet vendors, and we're having active conversations as we speak to agree on a common way that these cards could be uploaded into a wallet, whether it's Samsung, Google, or Apple, and then being able to take that just like you do today, for example, with your driver's license in many states. Georgia went live with mobile driver's license a few weeks ago, had an opportunity to download my own mobile driver's license to do that, and then check in remotely, or check in, I should say, digitally via TSA checkpoint and just scan my driver's license from my wallet at a TSA checkpoint and never had to pull my driver's license out of my wallet. That was a really great experience. Somebody that's working in digital identity. We see that same process working here for insurance cards too. And so we're very excited about the fact that that's going to move forward. Next slide. As we talked about, the digital insurance cards, the CARIN IG itself defines those required data elements. The data elements themselves are focused primarily on CMS payers from the commercial side. And we have used the similar kind of data model in terms of how we think about that. And our payer community that we have, one of which is on the call today, has really looked pretty heavily at that and have seen various similarities in terms of what's required by CMS and others. The other thing I would just mention as an aside that's really important as a use case is Medicaid redetermination. With this technology, what's so great about it is that you can have this insurance card with this QR code that links out to a smart health link. And with Medicaid redetermination, there's an opportunity as the person's coverage changes in terms of whether they're eligible for core Medicaid, Medicaid expansion, the exchanges or others, that can be dynamically changed even though the person has the same QR code. That is unlike our world today in terms of the fact that you need a different card for that to happen. But in this world, we can actually do that dynamically, which will help millions of people maintain coverage over the time that they have this redetermination access. Next slide. So we are going to, at the end, show you a demo of how this QR code works, and then actually what pops up in terms of the actual interface itself. And so I'm going to hold off on this, but this is a screenshot of what that looks like. And then JP at the end is going to be able to show that to you once we get through the session deck. Go ahead. Next slide. As we mentioned, what does it enable? It's really the ability to download, display, and share that card. As we mentioned, it doesn't only involve just the scanning of the QR code. That's obviously important and is available and is a use case for doing that. But hopefully it involves the seamless mobile ability to upload that. So you can imagine a world where whatever the case may be, you have your provider app, you have your CVS app, for example, that comes and says, you know, hey, do you have your insurance card that you can share with us? And you can click a button that shares it from your wallet, digital wallet, up into the app of your choice. Again, all patient directed, person directed, and you don't have to have a scanner to do that. You don't have to have any other abilities to make that happen. It just kind of upload into the wallet itself. Hopefully it does eliminate over time the plastic cards, but obviously it won't completely eliminate that. And then we talk about real-time eligibility checks. The workflow here is that the individual can upload their card. And once they upload that card, again, it will be cryptographically signed, et cetera, and have that information. And then the actual provider, the pharmacy, the payer, whoever is doing the eligibility check will run the common 270, 271 associated with eligibility. They'll do that on their side. And that'll still be run the way it is today. But the good news is they're going to have more updated, again, signed information for the individual themselves. So again, eligibility check is a completely separate process than what we're talking about here, but it does facilitate, hopefully, the ability to do that more streamlined and more in real time. I will also add that it also promotes the ability of doing what we call real-time pharmacy benefit check, which is the ability of not only for you to upload your card and then for the individual payer, provider, pharmacy, et cetera, to run an eligibility check, but then to be able to say, hey, here is in real time how this drug that your doctor is prescribing to you affects your formulary, your benefit information, your out-of-pocket costs, therapeutic alternatives, and some of your cash price. And we have obviously, CARIN's developed an implementation guide to do that and working with the major PBMs to implement that. Last slide, I think it is. 2 more slides. What are the benefits? I think folks recognize this. Certainly there's a ton for patients, ton for providers and health plans. Everyone benefits in this type of a model. We're excited to talk to our panel to talk more about that because we have representatives from each of these areas to talk in detail about what they see as the benefit of doing this. And then I think it's our final slide. How you can get involved. As with everything HL7 related and WEDI related, it's all openly available to the public. We would love your comments and thoughts about this. You can download the specifications at smarthealth.cards. You can download the HL7 implementation guide here. Breaking news, and this is great timing by Michael and Robert. I don't even know if they knew they did this. I think we told them initially, but tomorrow there is a CMS Connectathon that is free and open to the public. I hope everybody joins it. As part of that Connectathon on Wednesday from 3 to 5 p.m. Actually, it starts today. But as part of that Connectathon from 3 to 5 p.m., there's going to be an overview of smart health cards. We're going to go through a similar overview as we've done today, and you're going to see testing in real time tomorrow from 3 to 5. So you can see that on the CMS website, look at that, and we'd love to have everybody, as many people as possible participate in that effort. You can always join the Zulip chat. There's a distribution list so you can know when our meetings are and when things are occurring. And then there's also an ability for, I know you meant to do that, Michael. There's also an ability for you to participate in the September Connectathon if July is, obviously tomorrow is too soon, but we will have a track at the September Connectathon where we'll be testing this. And then you can always look at CARINalliance.com or email us for more information, or if you'd like to get participate in the actual development of these standards as well too. So with that, I think we're going to turn to our panel. So we'll go to the next slide. As mentioned, myself at CARIN Alliance and Leavitt Partners, we also help develop the Helios Project, which is an organization that is focusing on public health data modernization, working with the CDC and ONC. JP Pollack, who's the co-founder of the Commons Project, who you just heard from. Jason Teeple, if you guys could come on video too, as we're calling you out, that would be awesome. Enterprise architect with Evernorth. He's going to talk about from a payer perspective what's happening. Rebecca Angrove, who is the evaluation and patient experience, oversees that for the Patient Advocate Foundation. Heather Lopez, who's the vice president of physician payment and practice at the Medical Society of State of New York. She's going to talk about this from a provider perspective. Upen Patel, who is the founder and CEO of Anil. He is a vendor in the space who have been working with digital insurance cards for a while and is looking to potentially transition to this new open standard. And Robert Tennant, who's the VP of Federal Affairs for WEDI too. So with that, if we could take down the slide presentation and let's have a conversation with this. So Jason, you're first up on the hot seat here. You are a payer with Evernorth. And for those who don't know Evernorth, Cigna and all of its associated companies, there's more than that. And you can explain better than I can the family of companies within Evernorth. And you're responsible for interoperability there. Give us a sense from a payer perspective, how you guys are thinking about this and why this is important to you.
Yeah, I think it's important from a payer perspective because it gives us an opportunity to engage the consumer at a level where they're already engaged through their mobile device most of the time. And then it also gives us an opportunity to look at how a patient can take their clinical information and make it available to other consumers. So while the space is still relatively new to us, we're still trying to engage, like, how do we make sure that the patient or the consumer has information that's relevant to their clinical experience, whether it's from the digital insurance card, right? Or for the additional clinical information that we could potentially make available. If you look at like the regulatory space with the provider access API and attestation, I think there's usability there. So there's spaces where we're looking at it as a means of kind of simplifying the conversations with providers and patients and payers. So making sure we all come together.
Awesome. Rebecca, help us understand from a patient perspective. Give us a sense. Each of us individually certainly are patients, but you're with the patient community every day. Give us a sense of like the frustration. I think we probably all could share our own experiences about sometimes coming into a doctor's office who they don't know you and you have to fill out the same paperwork over and over again, but give us a sense.
Yeah, I mean, any way that technology can reduce that burden, absolutely. I know with the patients that I work with, there's challenges around getting things billed correctly, billing to the right insurance, people that change insurance frequently, having some sort of technology that supports knowing what the most up-to-date insurance and insurance plan is, right? So all of these things patients struggle with. And as I think about this technology being rolled out, I'm really, really excited for the opportunity to not only streamline that patient experience at check-in for billing and for kind of the shouldn't say cost savings, but being billed correctly, but also potentially, having these QR codes that can connect patient information, house EHR information. I just think the possibilities are endless, and this is a really exciting first step into it.
Awesome. Thank you. Heather, from a provider perspective, love to get your thoughts. Obviously, there's a lot of burden that providers carry post-COVID, right? In terms of where they are mentally, physically, emotionally, in every situation. We have this workforce shortage that we're dealing with and all types of other burdens. What does this do to help providers?
So from the physician and provider standpoint, I think that this could ultimately turn into a huge game changer, especially in the event that the payers are involved. Day-to-day operations struggle within the offices because of these tedious administrative burdens. So, if you have something that is definitely pulled in and readily available, it cuts down on office supplies. It cuts down on the staff's time in verifying things. Also, if it was to go to a different step up and level, there are medical records, excessive medical records requests that happen day in and day out. And if the payers have the access to this information, it would truly give back the physician and providers the time and their staff, the time that we need to focus on what what we're here to do, payers and providers, and that's our patients. Get the patient in the center and get back to taking care and being able to spend that time with the patients.
That makes a lot of sense. Now, there's this other thing out there called revenue cycle management that I've heard about before, Heather. It'd be great to just understand, like, what is this? How does this play a role in that process? Does it help? Talk to me about how this gets integrated and potentially helps that gap that exists today.
Yeah, so I mean, as it stands right now, we all have doctor's appointments. A lot of us try to schedule them within a certain period of time. And so our deductibles and co-insurances are fluid. So we may have a doctor's appointment this morning and a doctor's appointment tonight. If we pay or copay or a deductible, say we write a check out for $500 because we know that's going to fall to our deductible. When we go to the next provider a few hours later, that information is not going to be available. So I think that it will ease confusion and all around from the staff's perspective, from the patient's perspective, and that it will have a real time on that and really be able to the physician's offices will be able to know what exactly the part that the patient is going to pay and be held responsible for it, rather than having to take that guess, make a phone call, sit on hold. So it's really a great benefit to the offices as well as the patients.
Thank you, Heather. Anil, UPenn, you are a vendor in this space. So tell us, does it work? I mean, does this thing actually work? And if so, what does an open standard do to help actually proliferate this across healthcare? What are your thoughts?
So thank you all for having me over here. We've been working on this digital insurance card for quite some time. Ryan's point of view about the open standard, which is something absolutely required at this point, because we are very limited at this point to the payer that we work with. And we have only limited access of the information to share with the members. So having these open standards, allowing us to share the same information, patient carries only one card, and that from the background dynamically changes wherever they go, whether it's a payer change or whether there is a provider change. The information flows along with the card for the members to have the access of it. So we are looking forward to have this particular standard as soon as up and running. It technically becomes a switch, a hub for everybody to exchange the informations, and that fulfills the need of what CMS is visioning about this CMS interoperability, to sharing the informations with just a one device, and that is your membership card. So we look forward to working on that.
Awesome. And is it working today, UPenn? You guys have a solution, right? Today is proprietary, but tell us your experience real time, in real world experience, I should say, in working on this.
Yeah, so absolutely, I can share that one. We technically started this whole program as a part of CMS interoperability requirement to giving the access to the member about the blue button data. A lot of people know that one blue button, that CMS stores the information about the member. We open up that dialogue with the payer as a part of the CMS requirement, and we publish this digital card along with CMS interoperability. It is quite amazing experience to look at it. The numbers, what we see is a plan who is using this technology today as a part of the CMS interoperability. We see the adoption of 46% of the populations utilizing this mobile device insurance card, which they can able to download it. They can transfer to any provider wherever they want to send it. They can access their eligibility data. They can access their authorizations, referrals. They can see the claims. It's all part of the one access. That's it. And then we are seeing a great success on that particular plan. But the moment we open up the open standard, what we are working right now on a FHIR and all those different things, I think that's going to open up the door for the portability of the information across all the payers, all the providers, whoever wants to participate with that. But we see a great success with our current use case, what we have it with the Medicare Advantage plan.
Thank you. JP, I'm going to turn to you. We got a good question in the chat. What if the card gets lost? Won't random people have access to personal health information? Can you respond to that for us?
Yeah, absolutely. And a great question. I think these kinds of privacy and security issues are front and center whenever we're talking about new interoperability technologies, whenever we're talking about, patient access to healthcare information, right? Giving the education to consumers about what it is that they're downloading when they click on this smart health link, who in fact they should feel comfortable sharing these data with, how they should keep it safe, right? So all of those things from an educational perspective are very important and need to happen. From a technical perspective, there are some things that we do certainly to protect these information. So when the data are in the cloud, there are several different steps of encryption, passcode protection, expiry, and so on that protect the information, so that we shouldn't have to worry about randomly people crawling and stealing millions of insurance cards from a particular payer. And then to exactly the use case that you're talking about, there are a couple of technical tricks that we have to help in this situation. One is that the smart health link, unlike a smart health card or unlike even your physical insurance card, if you know for a fact that this information is leaked out somewhere, that someone got a copy of your QR code that shouldn't have, you can go and you can revoke that. And the data can be deleted from the server, and you can update your smart health link, and then those information will no longer be accessible and shareable. Another technical trick that we have is that the smart health link technology supports basic tracking of how many and which IP addresses have viewed specific smart health links. So for example, payers could keep track of this and look for anomalous behavior, or even users could keep track of these sorts of things. And if you notice that your insurance card is being viewed thousands of times when in fact you only shared it with the one doctor, it might be time to update that. So much of the same sorts of fraud prevention tactics that are in place for credit cards and other digital technologies could be in place here as well.
I would just add, in addition to all those, JP, by uploading the card in your wallet, and I've had this experience with mobile driver's license and other things, it's actually being stored in the hardware of your phone, right? It's not being stored in a cloud somewhere. So I think that's really important. And the other perspective is that in order to access it, right, you need to have some type of biometric cryptographically abilities to unlock your phone and then be able to access the card itself. So a lot more, I think, protections we have in place and consent-based ways to do this than we have in the paper world today. If you lose your paper card, you've lost it forever and someone has taken it and things have occurred there. So we've tried to do our best. Delisa asked, what are the HIPAA standards associated with this approach? So the JP can answer this as well, but the HIPAA standards are related to the eligibility transactions. That's probably the closest one associated with that. And I'd love, Jason, if you want to chime in here too. We're not touching any of those HIPAA standards as it relates to this. This is outside of HIPAA because the person themselves are outside of HIPAA. Therefore, the standards that are in place can be able to find a way where it can make it into the wallet of your phone using these modern standards associated with that. But then once it goes back inside of HIPAA, goes to a payer, a provider, or a pharmacy, as I had mentioned, that's where the HIPAA standards come into play and the eligibility transactions associated with HIPAA would occur. Jason, would you add anything to that?
No, Ryan, you're exactly right. Like that's one of the cautions I keep kind of throwing out to folks is that, a digital insurance card, Smart Health Links is not a replacement for the 270, 271 transaction. It could be a kickoff process or an informative aspect that is shared with the provider organization. So then they don't have to necessarily hand type in information. They can use it as a copy paste, put the information in to kick off the 270, 271. But 270, 271 is a mandated aspect. So we're not replacing that with this concept. To me, it's a supplemental side concept that can help facilitate the transaction. But we're definitely not looking at replacing that right now.
Good. Thank you for that. Robert, let me pull you into the conversation a little bit. You mentioned obviously the clipboard stuff that you guys worked on in Weedy a number of years ago. Just for the broader group's benefit, we used that work. No work goes undone here. No work goes, unrecognized. We use that work as an input to our CARIN IG for digital insurance card. In fact, I think we've listed it in the actual IG itself as a backdrop for what we did, because I know we reached out to you and a whole bunch of others who have worked on this problem for a while. There are no good ideas in healthcare, Robert. There's only an idea whose time has come, right? So to your point as well, having the wallet technology, having the individual mobile phones themselves. But what did you learn as part of that process? You mentioned a little bit about that up front, but what did you learn as part of that process that we could apply here as we're hopefully now, this is the time where this is going to occur, hopefully at scale?
Sure. Yeah. First, a couple of comments on the previous discussion. One on the value, and a lot of folks forget that in the real world of healthcare, these plastic cards are either scanned or they're photocopied, and inevitably there's a challenge in trying to transcribe the information. And my old group, the Medical Group Management Association, has done research to show that a really high percentage of claims are denied because of a transcription error for the member ID number. And so it's simple things like that that are going to change and make life a little bit easier for providers. And just one thing on the security, it's a great question about what if you drop your card and it's picked up. The same thing applies to an ATM card. Just because somebody gets your ATM card does not mean they have access to your funds, because you have an authentication method with your PIN number. So there's ample opportunities for security. But I can tell you, there's nothing new in healthcare, Ryan, as you suggested. We talked about all of these issues back, 8-10 years ago, and the same privacy and security concerns were raised, and technology can solve them. I think the difference between 2015, 2016, and 2023 is, I think, more acceptance of these types of technological solutions. If there was any kind of benefit to COVID, it showed that we can come together as an industry to create a standard that can produce a tangible product for the patient that is helpful. And I think the lesson learned that we need to apply here is we have to get the major players on board. This can't be a one-off solution, or providers will not adopt and patients won't either. We have to get everybody moving in the same direction. And that's, of course, the challenge for the industry.
We do have good news on that front too. We do have a number of the major players who have raised their hands and said they'd like to do that. I think a lot of that's going to happen tomorrow, so I don't want to give away too much there. Others are going to happen in September, but the number of folks have come to us and said, I think we're ready to do this. The other thing I would mention, one of those players actually is CMS too. So CMS actually has a Blue Button team that provide the Blue Button data to the individual. They're the CMS fee for service folks, and their team, we've been talking to them for a number of months now, and I think they're going to be actively involved in these connect-a-thons coming up. So that's also really exciting too. So Rebecca, let me turn to you. I want to pivot a little bit to equity and access. We want this to ensure that it's not just for people with smartphones. As JP mentioned, whether it's paper-based or other things related to that, it's really an equitable way to try to provide that access. But give us a sense from the patient community perspective, what they're going to need so we can reach as many people as possible with this new technology.
Yeah, Ryan, it's a really good question. I think when I think about the patients that we work with, it's a matter of not making a one size fits all, but really figuring out and meeting the patient where they are. So things like, is there an ability to still have a physical card? People really like that, right? So maybe that card has the QR code. Not everybody's going to be on a digital wallet. Other, concerns that when I talk to patients around this topic are, what if only some of their providers use it? And I think we already brought that up. You can't be carrying around this plus another insurance card, because we work with patients that have chronic and complex illness. They have a lot of doctors, a lot of sites, a lot of systems they're working with. And I think the last piece of it is you mentioned the word equity, which is a big word right now, but how patients look at it, and I think realistically is this technology that is supposed to increase access and be cost saving, not only for the systems, but also to make sure that patients are, billed correctly. Is that going to be available to patients in all areas, right? Or is this just going to be the most resourced health systems that are going to be using it? So when we think about health equity at a population level, making sure that this technology is available to everybody in some way, so everybody's getting the benefit, not just those highly resourced systems and communities. And around accessibility, we talked about this, and I would love to get more. I love the question about what if you drop it? We're going to get the same questions from our patients, like, how do I know what the most current code is, right? Like this whole thing about like changing and switching your QR codes. In this audience, it sounds great, right? If I try to explain that to patients, they would already be confused. So really working with that communication piece and helping, finding ways to help patients kind of transition, I think is going to be key. We're definitely trending in the right direction, right? Everybody's becoming more technologically literate. But for a lot of people, technology is still scary. What does this code show about me, right? Is there transparency? It's not this weird black box that like has secrets about me that only my provider can see. So things about building trust and transparency are important. But all of that is top of mind. And I'm sure this group would have a lot to say about all those topics.
JP, you want to chime in there?
Yeah, I completely agree with all of those points. And the transparency is sort of an extension of the education work that that needs to be done that I described earlier. One of the principles that we put into the technical and user experience guidelines for this specification is that if you're printing plastic or paper versions of these cards, or if you're displaying them on your website, or if you're a digital wallet maker and letting someone download them to their phone, that you are going to be required to display all of the key elements of that insurance card, and make it clear to people that when someone scans that QR code or taps their phone, that is in fact what they're sharing, to avoid some of those exact pitfalls that you've been describing. We also have every intention of working not just with the biggest insurance companies and the biggest academic medical centers, but also with state Medicaid agencies, with plans who are providing Medicaid services, as well as federally qualified health centers and the like, and the patients that visit them, so that we do in fact have understanding of the needs of everyone, not just no offense, but not just the Cigna members with iPhones who are going to Mass General Brigham, for example.
We like Mass General Brigham too. That's all right. But it's the idea is correct. Heather, let me turn to you from an equity access perspective on the provider side, right? There's obviously providers at big academic medical centers, but there's also the small rural underserved areas, right? Tell me about what that looks like from an equity perspective on a provider perspective.
So we all know that there are physicians and providers out there that are not on an EHR system, right? And how's that going to look for someone who's not on an EHR system? Question would be, would they still have the availability to use the website to gather the information, to perhaps cut down on the patient having to fill out the information? So time that the patient's sitting there, perhaps they could go there prior and have the information available for them to input themselves. It's a very different world, day-to-day operations wide, with a provider's office that's still on a paper chart system. So how would that look if in the event, like, could they utilize this to any extent that could help them save time with this?
Yeah, it's a great question. Was it rhetorical or was it specific? Or
no, it was just, from the provider's perspective, those folks that are not on the EHR, would they still be able to utilize something like this? And I think they could. I would just need that verified, that they would be able to still use the website to get the information that is on, whether it's with their own phone or whatnot, to get the patients and data, rather than having to have the patient sit down and fill out the information. So there still could be a plus, even though they're not on the EHR system.
Yeah, JP, it's a good question. Why don't I turn to you?
Yeah, absolutely. And so I think there are a few ways that could play out. So, we the Commons Project have built and plan to continue to support a free and open source just viewer or scanner application for these smart health cards, much like we did for COVID. So anyone should be able to open a website on a tablet or a phone or using a webcam on the desktop computer in the office and scan that card and display all of the information. From there, if they're not integrated with their electronic health record or other systems, they would need to be able to copy and paste that information from the browser into their, existing workflows. But that's still a step up from, having to photocopy cards and manually type in information. Yeah. The other thing that's quite possible that touches on one of the technical aspects that I mentioned earlier is the Smart Health link or the insurance card could be built in with a default viewer application. So, Cigna distributing their insurance card could not only provide, for example, the QR code that could be scanned by the special software, but they could do so such that when anyone scans that QR code from any mobile device or computer webcam, the link that gets generated would take them to a nicely rendered version of that card that Cigna or whoever would host. Then, we also believe that since this is an open standard, there will be any number of vendors providing these kinds of services and building them into the tools that they're providing their clients. So it's quite possible that, whether it's the, sort of admin services or EHRs or other technologies that the majority of folks are using in their office in some way, shape, or form, that these technologies would end up being bolted on to some of that as well.
And the other, thank you for that. And the other question, when it comes to cost, what is that going to look like to the physicians and providers' offices? What's that going to boil down to? And is it going to be something that they're going to have to pay another fee for to be able to access? Are we expensive wise? How much are we talking? Would it be per member? Would it be an annual fee? Would the EHR systems take up that cost, et cetera?
Yeah, and I think these are extremely important questions. As I described it, that sort of free viewer application will be a free viewer application. So at least that minimum copy paste functionality should be free for everyone to use. The next round of questions, I certainly don't intend to speak for the electronic health record vendors or others, but that will be up to them to figure out how to either eat or pass on those costs to their customers. And then I'm sure that any other sort of standalone services that stand up for this that are specialized, I'm sure would come with some costs to someone. But I think it's a little bit early to know exactly how those various costs would be passed around. But key for me is that there's always going to be a free solution to make this happen on some level. So that folks aren't really locked into any particular vendor or any fees if they're not in a position to do so.
And I think there'll be a free, well, I know there will be a free open standard, right, Heather, for everyone to be able to use. That open standard hopefully will be adopted at scale. And as those get adopted at scale, there'll be opportunities to use that, to JP's point. So we can't speak to what private entities will do or not do, but I think the idea here is that we really wanted to develop an open standard to make this as accessible as possible to as many people as possible. So Jason, let me pivot back to you on the payer perspective. Evernorth does a lot more things than just being a payer, right? You guys are in multiple different, you're really a multi-stakeholder, almost consortium now in terms of what you guys offer. You talked very briefly about the fact that you want to focus much more on the person, largely probably because of the entities that you guys have under your umbrella. Give us a sense of what that person centricity actually starts to look like and how the card potentially could support that.
Yeah, so I can't give away strategy or anything, but this is when you look at when you combine the payer, the provider, and the patient experience, there's a lot of synergy around the engagement methodology. Right now, you have to go into your wallet, pull the card out. We already talked about the workflow, right? And from an Evernorth perspective, we're engaged in all three of those angles. So we're trying to figure out where's the best way to engage with each of those personas, for example, and to accelerate their workflow. So we're actually engaging in a positive way and not in a negative way, right? We're trying to help the providers streamline the workflows and make sure that we reduce the errors that you see coming in from the claim side or for the 270s, 271s. We're trying to make sure that the patient understands what type of coverage they have when they go into provider office. So there's opportunities for us to use this digital insurance card and the smart health links to make sure the patient is engaged and informed of their care as they step into a situation. So that's why we're looking at the different angles. And you're right, because of we have pharmacy services, we have provider services, and we have payer services. We're in a position that we can look at that and start helping, evaluate what's our, from an industry engagement standpoint, how do we, move the ball forward and making sure that we have an interoperable solution. So it's not just Evernorth putting something out there. It's an industry interoperable solution that, works well for the patient, whether they go from a Cigna health plan to United to, one of the Blues. We want to make sure that the patient has a positive experience.
That makes sense. Robert, I'm happy to continue to engage this panel, but I really want to open it up to the folks, that 89 or so folks that are still on the call. If they've got questions that they would like to have answered, I'd love to be able to provide those questions to the panelists.
Yeah, just a couple of quick points. And, I'm struck by what both Rebecca and Heather said about what about either the patient or the provider that has not made the leap into electronic. How do we deal with that? And I'm reminded of my own car insurance company, which shall remain nameless. They stopped issuing plastic cards, and now they email or text the cards. And if you don't have a smartphone, of course, most folks will have an email address. They could go to the public library and print out their card. And so it solves that problem. So there's ways to get around this. And I think once folks see the benefit, more and more folks will transition over to be able to read the QR codes. And then how do we get the EHR vendors on board? This, of course, is going to be voluntary, but one option is to approach ONC, the Office of the National Coordinator for Health IT, about incorporating the technology into its EHR certification program. So then it's baked into the software, and it's much easier then for the provider to adopt the solution. So I think there's solutions to almost all of the problems. I think really the main one is how do we get to the tipping point where, and again, I'm really pleased, Ryan, to hear that we've got some of the large payers already on board, like CMS. And candidly, when they made the transition to the Medicare beneficiary identifier, the MBA, they went away from use in social security numbers. We urged them to take advantage of this transition and move to a machine readable ID card. They didn't quite do it then, but there may be a motivation to move in that direction now.
Yeah, I know Rebecca has her hands up, so I want to turn to her, but I will tell you, Robert, that one of the unique things that we have done over the last few years is we have these HL7 Fire Accelerator programs where the stakeholders are coming together and saying, here are the use cases we want to do. They're developing the standards and they're testing the standards. And as a result of that, what we're seeing from a public policy perspective is that ONC and CMS have shown a propensity to actually point to those standards that have literally already been adopted and tested by industry. So this kind of really nice circle that we've wanted for quite some time. We had it in WEDI with EDI and HIPAA, right? We had that great good circle of private sector, public sector collaboration. I think that will continue, at least, that's what we're seeing in terms of what this looks like. But we do need private sector entities, consumers, providers, patients, payers, others to come around the table and say, look, there's an opportunity here. We need to test this. We need to ask those hard questions, and we need to try to get answers for that. Rebecca, let me turn to you with your comment. Go ahead.
Yeah, I just wanted to respond to Robert, and you make some great points, even looking at other industries and what they're doing. I think from a patient perspective, though, we have to remember that just because there are workarounds, the goal of this technology is to make everybody's life easier, including the patient, and make things more accessible. So yes, maybe a patient who doesn't have access to some of these technologies can go to a library to print something out, but now you're adding chores to a patient, right? You're adding burden. And so as we work through these things, just keeping in mind, specifically when we're thinking about equities, some of those patient communities and patient populations that are lower resourced, have disabilities that make it harder to do some of these things, whether that is working with technology, printing, going different places, just making sure they're part of the conversation and the thought. Not everybody lives on a computer like I know I do, and most of us are, right? We're in front of this all day. Technology feels very streamlined and seamless to us. But there's a lot of people where it seems like a very small thing, but these are big hurdles to get through. And so I just want to bring that to the top of everybody's mind as we're thinking through these technologies, right? They're there to make life easier and make things more accessible to everybody, but we have to make sure that it is for everybody and just not for those that are already comfortable with technology. And I know, JP and the team are thinking through all these things. So just continue to talk about it.
We've got another question that came through. Can you describe how the smart card and particularly Smart Health Links works for replacement cards or when the card issuer health plan changes? Thank you, Mark Scrimshire. Good to see you. Thanks for answering that. JP, do you want to respond to that briefly?
Yeah, sure. And so I think to some extent, the same kinds of practices that insurance providers follow today will follow from a technical perspective, right? We have, again, we have technical tools that can help facilitate that. So insurance cards can have expiration dates so that, when your plan is set to roll over at the end of the year, we can make sure that those existing cards stop working. Cards can be revoked such that if you lose coverage, the insurance company can in fact make it so that that's clear when someone tries to scan your card. When your plan updates, one of the nice things here is that you shouldn't actually need to receive a new physical card or even a new QR code. The data that's at the end of that Smart Health Link can simply be updated by your plan. And the next time you use it, it will be reflected in your current card. So I think, again, there are, like much of this, there are some technical things that we can do that make some of this easier than in the real world. And we're going to go through a transition phase where at first it will probably work exactly like it does today. You'll lose your QR code, your plan will be updated, something will happen, and you'll go back to the website and you'll figure out what to do. But hopefully in time we can get to a place where this is much more seamless and the cards in your wallet are simply updating or expiring and changing as your plan and coverage changes with you. I don't know if Jason has any thoughts about how they would be thinking about this, but that's what I've got.
No, that's a really good point, right? Because over time, your insurance, your coverage information changes. So having the ability to have dynamic information instead of having to get a new card every few months, if you happen to make changes within a plan, is really critical, right? It drives down costs from a payer perspective, but from a patient, they have the confidence that they know that the information they have is the most current information. And that's critical, is that, they have the confidence in the information that they're seeing.
Another question came through. How would this work when a provider perhaps isn't in the digital space, like those who don't have the ability to send e-prescriptions or lab orders and do everything manually, and the patient has only the digital card? Could that be a valid use case? Heather, you have your hand up and you're the perfect person probably to answer this. I know we talked about this a little earlier. You want to chime in here?
Sure. Could that be a valid use case? So I would surmise that they would be able to utilize that free option to be able to pull the information that is needed for the labs and scripts that have gone through medications, etc. Even if they don't have the EHR, they still would be able to access that patient's data to be able to move forward with. Is the question specific to like for the providers, from the provider standpoint or from the patient standpoint?
I think they're asking from the provider standpoint is what I'm meaning. Yeah.
So I think that the provider and how we've talked about in discussions that they would still be able to pull via the website free option and still gather that information that they're looking to get.
Got it.
And JP can verify that, but I would surmise that would be the answer to the question. But I did have my hand up for a different question.
Go for it.
So many times the physician's offices will receive a denial advising that the patient wasn't eligible. So then the practice staff has to go back to the patient and try to grab all of that information. And sometimes it isn't until months later that they've received this denial. So then they go back to the patient and there's back and forth. Where I'm getting with this is it takes a lot of time. When they finally do get the information, they will then get a denial from the insurance company saying of timely filing. In New York State, there is a law that does protect the providers to be able to fight that. My question is, will the insurers be able to see the product and the date range that the patient was eligible for, because that could cut down on a lot of denials and back and forths for both parties?
Yeah.
Go ahead, Jason. Go ahead.
Yeah. So I think my response isn't going to be a great one here, Heather. I think I want to learn a little bit more about that workflow so I can give you a more accurate response. I apologize. That's something I just have to kind of work through my head to understand what you're talking about. It sounds like there's opportunity there from a payer perspective, but it's until I better understand where you're coming from. Let's connect offline. I'll send you a message.
Sure, absolutely. This is one thing that frequently comes up. And there's a lot of back and forth with the payers, back and forth. And it definitely, I'm happy to share and have examples probably as well. Thank you, Jason.
We have any other questions from the audience? Yeah, super important. I think that's a great way to end, Rebecca, and I'll turn it over to Robert to finish up here. But we hope that this is the start of a conversation, not the end of a conversation. And this is opportunities. Like I said, a few of us have been working on this for quite some time. We've seen the benefit of this. As JP mentioned, he and I, along with others, worked on this as part of the vaccine credentialing initiative and smart health cards during COVID. Tremendous value from that. And we said, look, there's good opportunity potentially here as well. And again, there's great opportunities. They will send all the slides out to this group. So you'll have them. Great opportunities to get involved, all free, available for folks to be able to engage. Come tomorrow if you want to hear more and see this actually in real life to the CMS Connect-a-thon if you do have the time. But yeah, Rebecca, great point. Just really helpful to say this is really the start of that discussion. So Robert, with that, we'll turn over to you to close out.
Yeah, maybe I'll just ask one question of you and JP. If folks are interested in getting more involved in the project, what's the best next step for them?
Yeah, that is that last page of the presentation that we had. If Michael could go back, there it is right there. So when that goes out, you'll have all those links there. You can sign up for the email distribution list that's under there. You can join the Zulip chat, which is the Fire Zulip chat itself. You can participate in the Connect-a-thons, either the one tomorrow or the one in September at HL7, for example. And you can use the specifications as well to make that happen. So there's a lot of different ways. I'll give you one other opportunity as well for those that are technical online. We also have a YouTube channel, and I'll put that in the chat here right now because I forgot to include this link, where folks can go to. They have, there is a YouTube video on there called the HL7 Digital Insurance Card Working Session that we did about 3 months ago. It goes into a lot more technical detail about this, Robert, how the digital insurance card and how the CARIN IG for digital insurance card, how those how the smart health card and the CARIN IG for digital insurance card, how those two things work together. So, and there's some documentation as part of that as well. So lots of places to get more information, more involved as well.
I appreciate that. And I'm going to suggest maybe we invite you back at some point after you've gotten some buy-in from CMS and other payers, because I think the more we can spread the word on this, I think the more we'll get providers, patients, payers, and vendors engaged. So I just want to thank you, Ryan and JEP, for sharing the information. I want to thank the panelists, Heather, Becca, Jason, and Yupin for giving us some valuable insight from each of the different stakeholder perspectives. WEDI is right in the center of this. We're very excited to really present this type of information. Michael, if you can go to the last couple of slides. I did want to remind folks, we do have our summer forum coming up in Chicago, the first couple of days in August. And, we're going to be focused very much on automation of the revenue cycle. We're going to be discussing the API FHIR solutions for prior authorization. We're going to be talking about electronic attachments, and we're going to talk about all the latest standards. And we sort of breaking news for us is we're going to have CMS in Chicago hosting some listening sessions to discuss some of their key issues as well. So we're looking forward to seeing you either live or virtually in Chicago. And with that, I think we can close out the event. Again, we wanted to thank you all for attending, and thanks to our speakers. And again, we will send you all the slides and the transcript, the recording to your email address. So thank you again, and we hope to see you at future WEDI events. Take good care.
Thank you.